Trustee L. Gopalakrishnan sir, our respected Secretary Dr. Kannayan sir, our respected Principal ma'am Dr. Brinda ma'am, and our HOD ma'am for giving us this golden opportunity to organize such a webinar. The Alumni webinar series is a student development program that aims to help students connect with our alumni in the field. I welcome Dr. Surendran sir,
our
Associate
respected Secretary
Professor and
Dr.
Head
Kanayan sir,
Department of
our respected
Psycho-oncology
Principal ma'am Dr.
and
Brinda ma'am,
RCTC
and our
Cancer
HOD
Institute,
ma'am
Area,
for
Chennai,
giving
to
us
be the
this
resource
golden
person on
opportunity to organize
psychosocial
such a
aspects of
webinar.
cancer care.
The Alumni
We
webinar
welcome you, sir.
series is a student development
I
program that
invite
aims to
Arshita
help
to
students
introduce our
connect
resource
with
persons of
our
today's webinar.
alumni in the field. I welcome Dr. Surendran sir, our respected Secretary
and
Dr.
Head
Good evening,
Kanayan sir,
everybody.
our
I take
oncology
immense
ma'am Dr.
pleasure
Brinda
in
ma'am,
introducing
and our
our
HOD
resource
ma'am
person
for
for
giving us
today's
this
webinar,
golden
Dr. V.
opportunity to
Surendran,
organize such a webinar.
Associate Professor
The
and Head,
Alumni webinar
Department of
series is a
Psycho-oncology
student
and Resource
program
Center for
that aims
Tobacco
to
Control
help to
Cancer
introduce our
Institute,
resource persons of today's
WIA,
webinar.
Chennai.
Alumni in the field.
With 18
I
years of
welcome
experience
Dr.
in the
Surendran
field
sir,
of
our respected
psycho-oncology,
Secretary
Dr.
and
V.
Head
Surendran is currently
our
heading the
oncology ma'am
Department
Dr.
of
Brinda ma'am,
Psycho-oncology
and our
and
HOD
Resource
ma'am
Center for Tobacco Control at Cancer Institute, WIA, Adayar. We are very proud that he is an alumni of our very own PhD College of Arts and Science. Sir has done his master's in psychology at PhD College of Arts and Science from the year 1997 to 1999. He is trained exclusively in tobacco control and cessation by the Union, Pain and Palliative Care, Cognitive Behavioral Therapy, Australia. He has published more than 13 scientific articles in both national and international journals and has also contributed chapters to edited books. Dr. V. Surendran has produced 23 psycho-oncologists who have been placed successfully at various comprehensive cancer centers across the country. To his credit, he has initiated various patient support group programs and designed intervention modules to improve treatment adherence. One of his highly appreciated initiatives is the free wig program for patients receiving chemotherapy. Dr. Surendran is involved in various projects for cancer patients, including developing tools for assessing psychosocial well being of cancer patients, offering free breast prosthesis for patients who underwent mastectomy, offering interventions and cognitive retraining for pediatric and adult cancer patients. He is one of the expert members of the State Policy for Cancer Care in Tamil Nadu. He represents India for Asia Pacific Psycho-oncology Network and the chair of the Asia Pacific Psycho-oncology Network meeting scheduled in January 2021. Additionally, he is also the chairman at the Ethics Committee in the Department of Psychology at WCC Chennai. It's a pleasure to have you amidst us today, sir. This session is all yours.
Thank you. Thank you, Ashita and Sindhu, for a wonderful introduction, and hope all of you can hear me. Yeah. So Dr. Jyoti, thank you for inviting me to deliver this such a wonderful evening. As an alumni of PSC College of Arts and Science, it's a proud moment for me to talk about the field which I'm associated with. More than the lecture, I would like to share our experience in the past 18 years. So thank you once again for all of you joining this evening on a Sunday. It's a holiday for everyone. So hope you enjoy this session this evening. So hope I'm audible. If any doubt, please message me. I can chat box, I think. Yeah, I should be able to share with you. Can you all see my window? My PPT?
No.
Now?
No. Yeah. Yes.
Yes?
Yes, yes.
All right. Okay.
So could you go for the slideshow, sir?
Yeah, I'm coming.
Yes.
Okay. Now? It's fine?
Yeah, it's fine.
All right. Okay.
In slideshow, yeah, yes.
So you're able to see now?
Yes, sir.
All right. So I'm reminded of 97-99 batch of the psychology, masters in psychology, where I studied, in PSG. It was a golden memories, the place where I learned psychology. And so today we are able to apply whatever we learned in the field. So we are always thankful to our teachers who taught us the subject in detail. So I would like to thank all of them at this moment. And to start with the psychosocial aspects of cancer, it's a very new field across the world. It's not even more than 3 decades old. In India, it's again a much newer field with lesser number of professionals opting for this field, but much needed. And I would say the need is increasing on a day-to-day basis as there is more number of cases. So we are living in a place, country where more population and different culture, diverse culture, varying degrees of development and healthcare in this country is always a major challenge. So when it comes to cancer is one of the biggest challenge for anybody for that matter, any government is concerned. It's a non-communicable disease and the number is growing annually. It is on the rise. So in India, 1 in 10 Indians likely to develop cancer and 2 to 2.5 million cancer cases present in a given point of time, and 8.9 lakh new cases are present in every year. It's one of the leading causes of death in our country, and 1 in 15 die of cancer, and 4 lakh deaths occur annually. And this number is increasing. That's why we say this is a greater concern. So everybody is paying close attention now. You all might be aware that, the number of cancer centers is shooting up. If you go back to 2000 and today, if you compare these 20 years, 2 decades, there is a tremendous change in healthcare, particularly in cancer care. So cancer, it's a term used for disease in which abnormal cells divide without control and are able to invade other cells. Cancer cells can spread to other parts of the body through the blood and lymph systems. Cancer is not just one disease, but many diseases. There are more than 100 different types of cancer. The causes for cancer, though it's very difficult to say this is the exact cause of cancer, however, with the available literature, genetic is one of the important reasons for developing cancer. Food, hormones, radiation, tobacco and alcohol use, workplace and environment, stress, and virus. So these are some of the causes that leads to cancer. And generally, when someone is diagnosed with cancer, radiation, surgery, chemotherapy, these are the primary treatment generally considered. However, it changes, site to stage based on the stage that is being decided by the oncologist, treating oncologist. Of course, I wanted to give you an overview of what all these are about. So, life after cancer. See, when we hear the word cancer, it is always, people associate with death. That's why it's being considered as one of the dreadful disease, and people have the stigma that if someone is diagnosed with cancer, and that's the end of life. That's how it is being seen all these years. But that's not the case. There is life after cancer. That's what I would like to make a point here. The only thing is, we need to detect the cancer early and go to the right place, get the right treatment on the right time so that there is life after cancer. But it doesn't come just like that. It always comes at a cost. That's what this presentation all about. So when I see cost in the sense, how it affects them, the psychological aspect of the individual and the family members diagnosed with cancer. So from diagnosis, becoming patient, receiving treatment, living with cancer, and life beyond cancer. That's how I'm going to discuss with you in the entire presentation today. So cancer diagnosis, it is generally acknowledged as a period of increased distress. So distress not only for the patient, also to the family members, anybody who is closely associated or connected with the patient. And it's always seen or always perceived as a death sentence to whoever has been diagnosed with this disease. That's how it has been seen. That's why the reaction to the diagnosis always, a very emotionally connected one. So one is fear of death or fear of separation from others and himself. There is a possibility for developing psychiatric disorders, communication with family is almost blocked by the individual himself, and developing panic attacks or other disorders when they hear the news, particularly the diagnosis. So denial of the cancer diagnosis, many a times, you all know, if you look at the trends, they go to different hospitals, seek advice from different doctors. They just like that, they don't accept the diagnosis given by a doctor. They always want to reconfirm whether it is true, and sometimes they may say that no, I don't think this is cancer. Is all so it's a mechanism by the patient, family members, or both avoid the reality of the illness, and that's where they use denial in many cases. So that is why in India, although patient has the right to know, and the medical community wish to disclose, there is always whether to tell, because the family always can you all hear me? So the family always tell the doctor and the treating physician that don't tell, because if you tell, it will affect them and he will go down psychologically. tell, but don't tell that it is not cancer, it is a tumor. That's how they say. So finally they tell something. When they tell the truth, and the patient will be in a state where that affects psychologically, that's where we are playing a great role in helping them to cope with such situation. So what happens when I told you about treatment? One is cancer, other one is the treatment. More than the diagnosis, many a time patients and the family worry a lot about the side effects or the sequel associated with the treatment. And sometimes the disease itself can uh, cause a lot of physical changes, and also at times the treatment as well leads to a lot of changes. So the changes in physical appearance, so loss of hair, and losing weight or gaining weight, changes due to surgery. Sometimes a person might need to lose voice, or losing a limb, or losing a breast. It depends on what was the diagnosis is all about. And changes in relationship with partners, family, and friends. And that is also there. When I say relationship, it depends on the age, how well they are connected to each other. There is a possibility for separation. And when I say separation in the sense of relationship, as well as and father, mother who is getting treatment, and the child need to be at home and who is going to take care of the children. So overall, it has a tremendous impact on the family as well as the patient side. And once the patient is diagnosed, there is high chance that the patient may need to be dependent on others, as well as change in their role as a in the family as a whole, and having to change their behavior. For example, if someone is smoking and they have to stop, no other go, and change in diet. There is a drastic change in diet, I would say, and adhering to medical advice. That's something that is very important. So overall, there is a change to the way they live life. So it is a sudden change that takes place all of a sudden. So this is something that overall impact of the cancer and its treatment. Let me take you through how it affects in detail. The first thing is, generally people worry, all of us worry about pain. So in cancer, 50% of these patients experience pain, and the cause of pain could be because of the tumor, where the tumor is present, and the treatment-related pain, generally the surgery and chemotherapy. Surgery-related pain may not be long-run one, whereas the chemo-related, sometimes it goes for a longer time, because generally chemotherapy is given for 4 months, 6 months, depending on the nature of the disease. And the post-operative pain, again, that's what generally people worry a lot about. Now, because of the advancement in medication, the pain can be controlled to a greater extent, along with the psychosocial care. And there are different types of pain: breakthrough, chronic, and acute pain. So based on the intensity of the pain, the medication or the intervention need to be given to cope or come out of the pain. The pattern, location, intensity, severity, aggravating factor, personal response to pain, all need to be assessed to understand the overall nature of the pain, so that we can reduce the pain. So always it is better to ask the patients what is the level of pain that they are experiencing, so that it helps the treating physician or the team to help the patient accordingly. Then another problem associated with treatment is the CINV, generally chemo-induced nausea and vomiting. This really causes distress to the patient. I would say not only to the patient, also to the treating doctor, the physician, because if the patient is on the grade 4 CINV, then definitely there is higher chance that the patient may refuse further chemotherapy, or the dropout may be high. Hence, it's very, very important that we address this concern, and because it's going to affect the quality of life of a patient, and it will hamper the healthcare professional and the patient relationship. So what happens, that will sometimes lead to maladaptive coping, and hopelessness, helplessness, and sometimes anxious preoccupation that, what if I develop the same symptom, or if it becomes worse when I receive the next cycle of chemotherapy, then that's going to be hard for me to continue the treatment. So that is where, see, now because of the medical, again, the advancements, there are medications available but it's very important that the psychological aspects of these patients need to be understood well, and you should provide a proper intervention at the right time. And another important aspects, particularly alopecia, which is associated with chemotherapy. What happened when everyone, whether men or women, who receive chemotherapy, there is higher chance that they may, lost their hair because of the treatment side effect. So it will be distressing for everyone, and it has been reported that 30% of these patients experience high level of distress, and it is associated with social stigma and affecting the social interaction. And from my experience, most of the women, they are not bothered about coming to hospital, whereas they are really bothered about going back home, fearing that people around them will ask what happened to their hair. So that's what a major concern. More than the treatment, more than the disease, they worry a lot about their body image. That results in low self-esteem, altered body image. So hence, it's very, very important that you take care of these patients, not only offering treatment, also you need to address these issues as well. That's when we launched a program, a free week for patients receiving chemotherapy, I think almost 5 years back now. That is well received. Initially, we all felt that maybe in our country, people may not be that much, they may not receive well, particularly weak. But it's not the case. Now, we are not able to supply for the demand that's being created at present. That's a huge need by the patients that, it really helps them because we provide natural wig, not the synthetic wig. So it really helps them. And another important aspect that is associated with treatment is the fertility issue. And again, it depends. The impact of this aspect is based on the gender, age at the time of treatment, type of therapeutic agent, and the radiation and the amount of radiation received, the total dose, single versus multiple agents, length of time since treatment. All these matters when it comes to fertility issues. But that will be a shock if someone is told, because of all these concerns, if there is a higher chance that someone may lose this aspect, then that will be an emotional roller coaster for a male or a female. They will be in a shock, grief and loss, anger, anxiety and uncertainty about the future, frustration, isolation, loss of control over life direction. So that's why many a time people do ask a question, why me? Why it's me? So another important aspect. So there are a lot of things that a psychologist must be aware of, because of course generally there are sperm banking and so many other newer options available. Even adoption is really picking up well. There is a government portal as well in this regard. But one thing is, the person who is offering intervention, particularly the psychosocial care, who are delivering the communication, they must be aware of all these and help these patients cope well and make a right choice and the right decision. That's very important. And central line infection, that's again, so why I included this topic is because we worked extensively on the central line infection, because it is most of the cases it is associated with the behavioral aspects of an individual. What happened when somebody is receiving chemotherapy, they will be put on a central line through which they inject the chemotherapy. What happened when people don't follow the proper hygiene mechanism, then that leads to infection. Once they develop an infection, that's going to cause a lot of problem for both patient as well as the treating physician. So it's very common. And with behavioral intervention, this problem has come down drastically in our practice. More than 50% of these patients who developed infection, just because of change in their behavior, the infection rate has come down. So So that's what. Then the next is the change in sexual life. It is not just because of the disease. There is a psychology, the psyche involved in it. The recent the qualitative interview which we conducted among women who underwent cervix cancer, and who received radiation therapy, we had a lot of issues, particularly with regard to the sexual aspects. And the male partner, they leave them and get married with some other women. These are the common issues they experience, and even they don't even show any interest in towards the sexual. Patient feel embraced to talk about their sexuality with their treating doctor. That's why a third person involvement is very, very important. Many a case the doctors do discuss, but the patients are not that much open for a discussion. That's where the open communication is very important with patients and the family members in this regard. Another important aspect is cognitive impairments, the chemo fog or chemo brain. We call it as, because the women who receive chemotherapy, when I say women, women with breast cancer. So what happened later point of time during their survival, many women came back and reported to the treating physician, the physician who they underwent, who treated the person, that they are not able to attend. Their attention span is reduced. Their concentration has declined. Their planning and working memory has affected. So that is when they started studying the aspects of the cognitive functioning of these patients. And now there are a lot of studies and which also concluded that there is a deficit in the cognitive functioning of women and children who received chemotherapy as well as radiation. So cognitive retraining is very, very important. So we need to help these patients to cope. So that's again one of the important intervention strategies that we need to apply here in this case. And another is treatment adherence. And when we say treatment adherence, so there are, say, for ideal example is like in diabetes. Even in cancer, there are cancers which can be cured with having a pill a day. One such cancer is chronic myeloid leukemia. It is one of the type of blood cancer. What happens is in this case, all they need to do is, someone is diagnosed with chronic myeloid leukemia. All they need to do is they need to just take one pill a day, and they need to come for a follow-up after 3 months or 4 months, depending on the dosage and the nature of the disease. What happens? Although these medicines were given free of cost, but many patients fail to take the medicine on time. They don't come for follow-up on time. When I say many patients, not just many, 50% of these patients who received free treatment at our institute were non-compliant. So we conducted a initial study to understand what was the reason. Then we came to know that the communication was a big challenge, as well as the attitude, dysfunctional attitude. I'm all right, my symptoms are fine, why should I continue to take the medication? This is something that really put them on trouble. So what happens in this case, if they stop taking medication, the disease may progress, because they are not completely out of danger, because they have to continue to take the medication in this disease particularly. So now we designed an exclusive intervention, video education as well as the psychoeducation. So that really improves the compliance to treatment among these patients, and the compliance rate has improved. I would say the non-compliance from 50 has come down to 10%. So treatment refusal is another challenge in oncology. Many a times, the number of patients who make this decision not very well known, but the number appears substantial enough to warrant close attention, because many patients, many a time they say, no, I don't want this surgery, I don't want this chemotherapy, I don't want to undergo radiation, fearing that it may affect me. So they refuse treatment. That is where psychoeducation plays a vital role. So the referral, if you get 10 referrals in a day, at least 3 to 4 referral maybe for treatment refusal. You need to talk to the patient, explain them, understand what are their concerns about refusing, the reason for refusing the treatment. So we need to address them accordingly, and you should be able to communicate the language which is understood by the patient and the same as what the physician has communicated. There shouldn't be any miscommunication between these three. That may finally land up, if you get into a miscommunication, that will affect the overall the patient. And stigmatization. So more than the cancer diagnosis, treatment, the society, the stigma prevailing in the society is what worrying to patient and family members. That's why most of the time they say, please don't tell anyone, and they don't even disclose to their own family members, the relatives, So the reason is the society's negative evaluation, social, emotional, and financial, because many times people don't support them emotionally. They don't talk to them. They don't touch them. They don't go close to them, and they separate them. Like how you do it in COVID situation, the same happens to a cancer patient. Not in all cases, but in majority, I would say. And many a times the family members do ask us, doctor, can I ask my child to sit along with the grandfather or grandmother or mother? So please remember that the cancer is not contagious, and it never spread from one person to another person. So the stigma, we need to alleviate this kind of social stigmatization. So I already talked to you about performance. So, and that affects even in working setup, it may affect their ability to deliver the work. And fear, body image changes, disabilities, death. When I say body image changes, just imagine, let me give an example. If young women, 40-year-old women diagnosed with breast cancer, been asked to undergo a mastectomy. Mastectomy means complete removal of breast. Just imagine, it will be very hard for anybody to accept. All of a sudden, one fine day, a doctor says that you have to undergo mastectomy. When I say mastectomy, it is the removal of breast. Then that's going to be very hard for a patient to accept. So that is where you need to help them understand the significance of undertaking the treatment. At the same time, the alternates to cope with this. Say, for example, nowadays, there are newer advancements available. There are different types of prostheses available. Say, for example, the silicone prosthesis, that is external silicone prosthesis available. That's not very expensive, but still poor patient may not be able to afford it. So we provide all these free of cost to our patients, even the cotton padded bra as well as the silicone prosthesis. And the second one, I would say the implant. So if a patient is affordable, then there is higher chance that the patient can go for implant, so that there won't be any difference between before and after the surgery. But these options need to be communicated to the patient, and you need to counsel the patient extensively and help them understand and accept the treatment. And when we say disability, say for example, osteosarcoma, a person who develops bone-related cancer in the limbs or upper or lower limbs, there are high chances that they may sometime they may lose their limb, and then that may result in disability. So all these may lead to fear in their life, because there is a sudden change from their routine. So they may find it very, very hard to cope with this. And again, death is something that really worrying for anybody, for matter even all of us going through now at this pandemic situation. Just imagine how it would have been to a cancer patient and their family members. Another psychological effect of the cancer and its treatment is depression and anxiety. So there are a number of studies which has been undertaken, and So it is experienced by 58% of the patients. So it varies from 0 to 58% depending on the site stage of the illness. And anxiety also, it is commonly present among cancer patients as well as the family members. And post-traumatic stress disorder, when I say post-traumatic stress disorder, many a time because they undergo painful invasive procedures, repeated hospitalization, separation from family members, painful complications following treatment, infertility and growth problems, physical changes, cognitive changes, all these experiences leads to PTSD at a later stage. Whenever they think about a follow-up, an appointment with the doctor, all these reminders comes to their mind and leads to anxiety. So that is something that we need to diagnose at the right time and offer intervention appropriately. So whatever I discussed so far, it is with the patient, those who are diagnosed with cancer on a treatment. There are another aspect to cancer treatment and care overall is the advanced cancer. Um, when we say advanced cancer in India, 70% of the patient report in a hospital, 50 to 70%, I would say, 50 to 70% report in a very advanced nature of disease where the cure may not be possible. However, there are higher possibility that these patients may have an extended life, which means prolonged life. That prolongation may be years, sometimes many years. I have seen patients lived even for 4 or 5 years after their diagnosis and treatment. So what happened when you tell them that there is no possibility for cure, but it's very hard for them to accept, anybody for that matter. So that results in demoralization, grief, and they use defense mechanism. There is high chance that the patients may attempt suicide, and the desire for death is very, very high. But that shouldn't be, and that is where the role of a psychologist is vital. So when someone is confronted with death, goes through these phases. First will be denial, they don't accept, and the second phase will be anger, bargaining, depression, and acceptance. So this is called DABDA. So DABDA it's a Kubler-Ross model of how a person goes through the death, the process of death. An existential distress, a source of suffering. It is classified in terms of whether the patients are focused on past, present, or future concerns. So what is their real concern, whether they think about unfulfilled aspirations or previous actions in which they regret. Say, for example, sometimes patients think about their habit, the use of smoking, tobacco. That something really make them suffer. And there are other way, where the family would have had a very, relationship issues, many other things. That also sometimes the past experience may interfere. Loss of personal integrity or loss of important occupational or social and familial role functions. When someone is suddenly loses these functions, that is going to really raise a great question among the individual, that why me question. Then future concerns. This is something very common in cancer care, particularly among the middle age and the aged people, because they generally worry about their children. Who will take care of my children? My children are not married. They're going to school. So all these would be kind of greater concern for the family. This is what we call it as an existential distress. So all these distress are experienced by cancer patients and their family members, and distress being dependent, meaningless in present life, hopelessness, loss of role functioning, feeling emotionally irrelevant. These are some of the other issues associated with cancer and the treatment. Euthanasia, this is completely not acceptable in our country, though patients do ask for it, but that's generally we don't appreciate that. And suicide and desire for death, of course, many wish, many attempt, many try, but we are there to help them, support, and cope with the sufferings, so that reduce the pain, suffering, so they cope, have a better quality of life, and they never think about this. So, and another important thing is this, I think I have already discussed with you. There are so many other aspects to the cancer care, particularly specific communication issues, prognosis, unrealistic hopes, desire for early and absent death, close calls, talking about dying, substituted judgment, just one more day, sudden change, can they hear us? All these bedside dynamics or another important communication related issues which a social science person must keep in their mind when they communicate with their patients. Breaking bad news is another important aspects. It's like dropping a bomb. Or tell something. There is mom effect. Nobody tells nothing to anybody. So when we communicate this kind of bad news to patients and the family members, and we use a model called Spike. So when we say Spike, setting up an interview, S stands for setting up an interview, assess the patient's perception of his condition, and obtain the patient's invitation to divulge information, then giving knowledge and information to the patient, and addressing the patient's emotions with empathetic response, strategy, and summary. So this is the very simple model found to be very, very effective in disclosing the bad news, which includes the diagnosis or prognosis or treatment options or anything for that matter. This approach can be adopted. So this, just one, there are many models. I thought I should share something, so that I chose this and shared it with you. Hope it's useful. Another important, so now I just touched upon cancer and its treatment, and how the end of life, in case if the treatment doesn't work to a patient, then how this advanced cancer would be. Now, another important aspect is the survivors. See, when we say 60%, 50% survival, 40% survival, which means that if 100 people treated, there is higher chance that the 40 will survive minimum of 5 to 10 years. The event-free 5-year survival is, they say, 40%. That means that 40% of these patients going to have a normal life. Okay, so those are called survivors. So they continue to experience health problems, psychological distress, then their social life disruption, even decades after diagnosis and initial treatment. All these are very common among these survivors. The psychosocial problems of survivors of fear of cancer recurrence, fear of the future, sleep difficulties, sexual dysfunction, fatigue, and loss of strength. When I say fear of cancer, 60% of these survivors experience fear of cancer recurrence. And fears of the future, and that is, I think, 58% of the patients, the survivors experience this. And 48% of the survivors experience sleep difficulties, and 48% again experience sexual dysfunction, and 2 out of 3 survivors experience fatigue and loss of strength. So there is a great responsibility for a psychologist or a psychiatrist, when a patient comes for follow-up. Not only at the time of treatment, even when they come for a follow-up, we need to pay close attention. That's why we are running a exclusive clinic called ACT. And specific psychological issues of survivorship issues are body image and sexuality, interpersonal and spousal relationship, post-traumatic stress, chemofog, which I explained you already, work-related issues, quality of life, and fear of recurrence. These are all the common issues experienced by these patients. And triggers for fear of recurrence are follow-up visits and tests, suspicious symptoms. So if, say, for example, if they had a cancer in one breast, if they have a symptom in another, then that's going to be a trigger for developing fear of recurrence. Then persistent treatment-related side effects, change in health, loss of weight particularly, death of a fellow survivor. If they hear that the person who received treatment along with them who died, then that's going to be a nightmare for these patients, because there are higher chances that they may develop fear of cancer recurrence. Times of stress, then idiosyncratic triggers, that is learned response, like the smell of medicine, sight of the hospital. When they visualize this, then definitely that is going to be one of the triggers of fear of cancer recurrence. Then factors contributing to psychological response in cancer or socio-cultural context, treatment options and decision making, psychological and psychosocial factors, medical factors. So let us see in detail. When I say socio-cultural context, treatment options, and decision making, changes in surgical and medical management. So that is something which really one of the factor which is contributing to the psychological response. Say, for example, if a doctor says that if a person is diagnosed with larynx cancer, after the surgery is going to lose voice, then that will be a greater psychological concern than a person who receives just the radiation therapy and come out quickly with oral cavity cancer. So something that's very important. Social attitude. If there is a change in their figure, for example, there is a facial deformity, then definitely that's going to be a great cause of concern for a patient as well as family. And public figures openly sharing their experience, that's again, say for example, many a time people don't talk about cancer treatment and associated factors, the good aspects of cancer, because nobody talks about it. Even in cinema and the movies, only the negative aspect of cancer is being portrayed. But now, of late, many movie stars, even in Hollywood, Bollywood, even our Kollywood, people started sharing their experience. I underwent this, so don't worry, you will be fine. That gives them kind of hope. So autobiographies, this also gives hope, public awareness of treatment and research. So all these are very important factors which really helps a patient to accept treatment. Psychological and psychosocial factors, type and degree of disruption in life cycle tasks, psychological stability and ability to cope, attitude towards illness, prior psychiatric history, availability of psychological and social support. All these are the psychological and the psychosocial factors which contributes to the psychological response to the cancer. And medical factor, stage of cancer at diagnosis. Say, for example, if someone is diagnosed with early stage, then that's going to be a good news for a patient. And if someone is diagnosed with a late stage, then that's going to be really a question to a patient and family members. So that's really going to lead to a lot of psychological disturbances. Treatment received. What kind of treatment received, that again matters. Availability of rehabilitation, whether do they have the facilities such as proper physiotherapy care, proper rehabilitation measures, or when I just explained you about these wigs and prostheses, whether these services available in all cancer centers, whether it is available in every center, then that's a question. If it is available, that's well and good. That's going to be one of the important factor that really determines the psychological coping of an individual. So then the support provided by the physician and the staff, that's again, that really remarkably improves the quality of life of a patient. And risk factors for poor adaptation, why people generally poorly adapt to the psychosocial aspect, is the more advanced disease, more intense and aggressive treatment, comorbidities, if they have diabetes or any other problem, poor doctor-patient relationship. All these are medical related factors. Then personal factors, the past history of trauma, someone in their family or some friend who underwent the same problem. When they hear the news, that's going to put them down. It's going to be a poor adaptation. Rigid coping capacity, helpless, hopeless outlook, low education income, multiple competing demands, poor interpersonal relationship, younger age. All these are personal factors, risk factors for poor adaptation. And lack of support, social support. See, I always insist to the family that more than the medicine, the support that is being given to a patient, that really improves a person's quality of life. That's something that we all need to pay attention. I just quickly pass on this because I think we need to finish it on time. Yeah. So psychological distress. So these are all some of the things, and the quality of life. So need for psychosocial care. So whatever I said was not a great concern for a treating physician till 1970s. The 70s is the year when many patients came back and reported to their physician that I'm surviving, but my life is not meaningful. That's when they started investigating the quality of the services and the quality of survival. So that's when the psychosocial care is being paid attention. The first person to start studying this is Jimmy Holland in 1970s. And she's the pioneer who really started working in this field. And today, the psycho-oncology plays a greater role, well received by the oncology community. And the psychosocial care, of course, this particular service need to be offered from prevention to end-of-life care, recovery, and survivorship. However, the intense psychosocial care is needed from diagnosis and treatment and survivorship, recovery, survivorship, and end-of-life care. So psycho-oncology is a multidisciplinary subspecialty of oncology concerned with the emotional responses of patients at all stages of disease, their families, and staff. It is also concerned with the psychological, social, and behavioral variables that influence cancer prevention, risk, and survival. So the field, there are two major psychological dimensions of cancer. One is the psychological response to patients to cancer at all stages of the disease, and the psychological, behavioral, and social factors that may influence the disease process, that is the psychobiological dimension. So the first one is psychosocial dimension, the second one is the psychobiological dimensions. These two are important dimensions that we need to pay. And the emergence of psycho-oncology, so stigma associated with the psychological and emotional issues in this medical illness. And even now, many patients, when they refer the patient to a psychology team and they say, I'm all right, I think I'm fine, I don't need to, I'm not mentally ill, that's what they say, but still a greater concern even today. Limited funds for research and training in the field, smaller number of psychosocial clinicians work in the area of cancer worldwide, less attention to symptom control and quality of life and well-being of the patient. So various facets of psycho-oncology, diverse avenues within the field, training in counseling and communication skill, development of behavioral and psychological intervention, measurements of subjective symptoms like pain, nausea, dyspnea, anxiety, and depression, and reduction of cancer risk and mortality. See, it's not only the treatment. Once you start the treatment, you need to work on it. Even the prevention, cancer prevention, the primary and secondary prevention, the psychologists play a greater role that you need to understand. Then societal views, understanding and assessing the changing views about cancer in the society, that's also important role of the psychologist. So distress. So generally in oncology, we don't prefer to use the term depression and anxiety. Rather, we are happy to use the term distress because it is less stigmatizing and well received by the patient, because all these cancer patients are normal like you and me. Anybody in the society can get cancer at any time. So you can't brand them that they are mentally ill. So this word distress is very, very less stigmatizing. So there is a definition, a multifactorial, unpleasant emotional experience of a psychological, which includes cognitive, behavioral, emotional, social, and spiritual nature that may interfere with ability to cope effectively with cancer, its physical symptoms, and its treatments. So this is a definition of distress, and it is being widely studied. And the magnitude of this problem is 3 out of 5 have severe psychological problems, particularly distress in cancer. The prevalence of distress among cancer patients is more than 45%. When I say 40% severe distress, I mean distress increases through the continuum of cancer trajectory, and the distressing phenomenon for both patients as well as physicians. And 30% of the patients were found to have high level of distress when physician breaks the news of cancer diagnosis. The term distress was chosen because it is more acceptable, less stigmatizing than psychiatric, psychosocial, and emotional, sounds very normal and less embracing, can be defined and measured by self-report. So very simple, and we have a simple tool to assess. This is called distress thermometer, and it is accepted, and this is being used in all cancer centers in wherever they have a psychosocial care unit. And it starts from 0 to 10, and 0 means no distress, 10 means extreme distress, and 0 to 3 is no distress, and 4 to 7 is mild. 0 to 3 is mild, 0 means no distress, 1 to 3 is mild, 4 to 7 is moderate, 8 to 10 is severe distress, and up to 3 no problem. So you can just monitor Whereas if the distress level is more, then you need to pay close attention and they need a psychological, psychosocial management. And more than that, see, you need to find out what is the reason for the distress. See, the right hand side, you look at it. So there is a reason, whether it is a practical problem, family problem, emotional problem, spiritual problem, or physical problem that you need to understand. So the implication of distress, non-compliance to treatment, uh, not motivated, dropout is high, poor tolerance, no treatment, poor tolerance to treatment, poor performance, functioning and adjustment, poor quality of life, studies report poor survival, a strained doctor-patient relationship, increased hospital. These are all the problems that generally experienced. So when you manage distress effectively, definitely patients are well motivated, less side effects, well adjusted, increased productivity and performance, and decreased psychological distress, and it improves the quality of life, and dropouts and better compliance, decrease in cost and hospital stay, and studies have shown survival benefits as well. So the management of distress. So this is the triangle model, which explains you how the distress can be management at the mild, moderate, and severe level. So you need to assess and offer interventions. There is a guideline which is available. It's called NCCN guideline for distress management, and the role of a psychologist, role of a psychiatrist, and role of a social work has been well classified, and there is no confusion in dealing with such problems. So we would always say that there is life after cancer, but not the so-called normal that you live, but it's going to be a new normal. That's what we always say. The life after cancer diagnosis, it's going to be a new normal. When we say new normal, there is a huge role for a psychologist, psychiatrist, and social work in helping these patients to come out of the psychosocial issues experienced by them. So we provide pre-treatment psychosocial evaluation, pre-treatment preparation, post-treatment rehabilitation, strong social support, distress management, reducing health risk behaviors, support to family and staff. So the general psychological interventions or supportive therapies, when we say we conduct a lot of support group meetings on a weekly basis. Say, for example, we run a separate group for women cancers, we run a separate group for pediatric, we call it a SMILE support group, the MLR support group, and we have a stoma clinic, and we have now TCC clinic. So we are running different clinic. Now we recently started ACT clinic. All these clinics were run by a psychologist at our center. So that really gives a big relief to not only to the patient and family, also to the treating physician. So group therapies, brief interventions, crisis intervention, and we even have the 5-minute cognitive behavior therapy that really helps. And so these are all the psychological interventions which are found to be very, very effective. Challenges, as I already stated in the previous slide, stigma associated with psychological and emotional issues in the medical illness is a greater challenge. Limited funds for the research and training in the field is again a challenge. Small number of psychological clinical work in the cancer across the world is again a challenge. We need more people to choose this field and work for cancer patients and their family members is the need of the hour. And less attention to the symptom control, quality of life, and well-being of the patient. RCTs are based one cancer site, not on quality of life. Few trained professionals available. These are all some of the challenges. Advocacy. We need to create more awareness to the oncology professionals. I would say more than oncology, we need to create more awareness to the psychology professionals, because many are still today not aware there is such profession exist to do even exist. That itself, first of all, I think we need to start with psychologists. Thanks for the platform in explaining about the role of psychologists in dealing with this cancer care. Policymakers and rehabilitation professionals developing newer guidelines, integrating psychosocial domain in routine care. So it is not just one man work, it's a collective effort. So when I say collective effort, Everybody has to join together. There is a role of a psychologist, there is a role for a psychiatrist, there is a role for a social worker, there is a role for a nursing oncologist, physiotherapist, there is a role for occupational therapist, speech therapist. It's not just one person's work. It's not just a medical oncologist. It's not just a radiation oncologist or a surgical oncologist. It's a teamwork. That's what we say. It's a collective effort. What happens when we all join together? It really improves the quality of survival, the quality of life of a patient, whether they are in a treatable condition or in an advanced condition, or even during survival. There are a lot of benefits available. I think within 1 hour, I don't think I'll be able to share everything that we do at our center. So I thought I should give you an overall picture about what the psychosocial aspect is concerned with in cancer care. So the greatest deception men suffer is from their own opinions. So we all must have a good opinion. When I say good opinion, positive opinion about ourselves, even after the diagnosis, that really matters. So mind really matters. Mind matters in cancer care. Thank you so much for your patient listening. I look forward to respond to your questions. Any questions?
Thank you very much for the wonderful presentation, sir.
Thank you.
I think they'll be posting the questions in the chat box. So as they post it, I'll just read it for you.
Okay, I'll respond to that. Okay, I think I could see few questions. Dr. Jyoti, should I respond?
Yes, please, sir. You can go ahead. Maybe I could read the questions for you.
Yeah, please.
Sir, could you please repeat the model you given for breaking a bad news?
It's a spike model. SPIK, spike. Hope you understood.
Could you please elaborate that? Like
SPIK. So when we say yes, S stands for setting up the interview, and P stands for perception, the patient's perception of his condition, whether they know about the disease condition well, whether somebody told them about already, how much they are aware of their current condition. So that's what assessing the perception of his condition. Then I stands for invitation to divulge information. The patients obtaining the patient's invitation, whether how receptive they are and how much information they look for, that you need to know. Then giving knowledge and information to the patients, that is the K. So provide knowledge to the patient. Whatever you know, you share to the patient about the diagnosis and the prognosis. And E stands for addressing the patient's emotions with empathetic response. Psychologists, you all know how to respond to the patient with empathetically. Then finally, S stands for strategy and summary, and give them summary and make sure that it is understood or well received by the patient, and their reaction to this disclosure is well received, and they are able to cope well. That's very, very important. And somebody raised a question on mom effect. See, mom effect is nothing but being mute. Who's going to tell to the patient? Who is to tell? It's me, you, or someone else. So what happens? Most of the cases, we don't tell anything. So the patient will be in dark. We need to avoid that. Instead, we should disclose using different models. Have I answered your question?
Yes, sir. Our secretary, sir, is online.
All right.
Sir is congratulating you and.
Okay. Thank you, sir. Thank you so much, sir. Proud to be a alumni of the PSG CAS Department of Psychology. Thank you for the opportunity. If no more questions.
Mhm. I have a question.
Please.
We handle the cancer patient because I also worked with the cancer patients for about 2 years, and I know I came for the training.
Yeah, I remember. Yes. Long, many
10
years ago. More than
Yes.
15 years, or 10 years, more than
So
15 years.
it is really like no have a very negative impact on us also. Like the previous day we have seen one patient, the very next day when we go, the bed is empty. So how to handle our emotions?
Yeah, that is very important. That's why, see, in cancer care, particularly the psychosocial care, very few people succeed because you must be able to balance your emotion. So that's very important. Good question, Dr. Jyoti, because I suffered in the initial days. I think first 4 years were really a nightmare for me because every alternate month I go to a surgeon and say, "Doctor, there is a pain in my tummy. I think there is a stomach cancer," and I go and sleep well. That's what they say every time. And the next month I'll go and meet another doctor. I say, "Doctor, I need to go undergo endoscopy. It looks like something is there in my esophagus." So whenever we see cases, we always apply to us and see. We assume that, oh God, I got a cancer. It took years to understand that no, we are normal, and we need to differentiate between the patient's problem and our problem. It doesn't mean that I'm not talking about disconnect, but connecting well and differentiating. And more than that, we should be able to balance profession and the personal life. These two clear-cut demarcations we must maintain, and sympathy, empathy that is needed as a professional, as an expert. At the same time, we should also be able to apply apathy. Apathy, when I say apathy, when the session is over, when you come out, then you should really focus on what you really do. So if we go with the same, then that's really going to affect your daily routine. So that's why balancing your personal and the professional life is very, very important in cancer care, which we are doing very well at present. It takes a long time to learn and cope and apply. Thank you for the question, Sodhi.
Thank you, sir, because I also experienced the same when I was there. And one question from the live chat. Sir, how to do counseling for cancer patients who suffer from stress and ignore their life without knowing how to cope up with their cancer environment?
Okay, so how to do counseling for cancer patients who suffer from stress? See, for example, when you use the word stress is a very common term. Unlike other counseling, generally what you apply in cancer, you must know what was the diagnosis, the reason for this cancer, and what is the treatment options, and you should know what is the prognosis and the remission to the treatment. All these the medical related information a psychologist or a counselor must be very much aware of. You are not going to talk to them about all this, but patients do ask all these concerns. You should be able to provide right information to the patient. So that's why the triangle, the doctor, patient, and the communication expert, the counselor, is very, very important. you are not going to do something different than what we generally do in psychology. The same CBT you are going to apply, the same relaxation technique you are going to give, the same the psycho education you are going to offer, but the approach will be a bit different from general setting. So for which you should know more about cancer and its treatment and its effect. So that's the little tricky thing. So for which you need a training. Definitely one must undergo training. Once they take training, definitely they'll be able to do a good job.
Thank you, sir. Another question they are talking about the pap smear test. It is not much prevalent in India when compared to USA. So,
No. Pap smear test is very common in our India. Maybe we are not aware. That's the only thing. See, there is a big program is taking place in the state of Tamil Nadu. I think NHR, National. I think there is a project. I'm very much aware. There was advertisement in the TV media. Even when you go for a movie, there was a big advertisement, and they did a street by street awareness campaign also on screening, early detection. That early detection is about pap smear test, and we are conducting the early detection in 5 districts in Tamil Nadu: Pudukkottai, Viluppuram, Gummidipundi, Tiruvannamalai, and Chennai. Now started in Kanjipuram also. We are doing a door-to-door early detection program for not only for cervix cancer, also for breast cancer. So what we do is one is pap smear test, and they do take a pap smear test, which is very much available in India. So people who are above 35 years or 45 years of age, and depending on the high risk category, and they must go for annual screening, particularly early. It's called an early detection program. And I think if these test is, if the pap smear test is repeated for 3 years and 3 times, I think every year for 3 times in 3 years, I think if all 3 tests are negative, and the patient can be happy that there is less chance that they may develop any such thing in the future.
Okay. Thank you, sir. Can you still more elaborate about the vaccination for cancer prevention?
Yeah. See, the vaccination is right now available only for cervix cancer. It is available. It's on human trial. There are some drugs, I think 2 brands are available in India. I'm not very sure about it. But the vaccine is available. But the tricky thing is the vaccine must be undertaken before their first sexual relationship or just immediately after the puberty. And the results are, I think, yet to see, because it's still under trial. We are yet to see the result. But they do recommend. What happens, there are a lot of challenges in this. Say, for example, if someone received a vaccine for cervix cancer, does that mean that the female need not to go for annual screening after 30 years? Means no. They still need to go for screening. So that's what a challenge in this healthcare.
Thank you very much, sir. Our principal ma'am has joined the session.
All right. Thank you, ma'am.
Hello, sir. Good evening, sir.
Good evening, ma'am.
Yeah,
Thank you.
I'm Dr. Brinda, sir, principal of this prestigious institution. So
Great.
your talk was right from the beginning. I was listening to your talk, sir.
Oh,
Since
thank you.
I am basically a biochemistry professor,
Yes, ma'am.
so I do research in cancer only.
Excellent.
So most of our PhD students
Yes,
whom I am guiding, so far I have guided around 6 students, PhD students.
Oh,
All
great.
of them are doing in different fields like breast cancer, prostate cancer, and also the oral cancer.
Okay.
They are doing now,
Oh,
sir.
great.
And we do also do the animal study, not the human trial.
Okay.
So we
In
go
PhD,
for the
ma'am,
mice
PhD, you
study.
have an animal lab?
Yeah, we do have, sir, and we also are associated with our medical college. So we have a Institute of Medical Sciences.
Yes,
So
yes.
there we used to get the mice and rats, and we do the in vitro studies as well as in vivo studies.
Okay.
Mainly liver cancer also one student has submitted.
Okay, ma'am.
So we do such type of
Excellent.
the
That's good news. Glad to
Yeah.
know.
yeah. And
We do-
one question, sir, I have, sir.
Yes,
This is again regarding this pap smear which you were telling, no, sir.
Yes,
So
ma'am.
this pap smear actually they are asking to do every year above those who are having that is above 50 years. So how many years we have to continuously we have to do it, sir?
3 years, ma'am.
Okay. So after 3 years, if it is negative, we can stop it.
That's what recommended.
Okay. Okay. But as you said, vaccination is also available, but we do not know how far it is for the even
Ma'am,
for the
there
age.
are there are there are good news. There are now newer drugs are coming.
Okay.
It is from our own population samples by the
Okay.
Indian scientists like you people. Many
Ah.
laboratory. It's coming from labs. Probably we need to wait for a few more years to get that.
Mm-mm.
Yes,
Okay,
ma'am.
sir. Sir, one more, sir. We are having the BSc, MSc, MPhil, PhD students, biochemistry
Yes,
students. So,
yes, ma'am.
are they allowed to come there for the internship training, sir?
Yes, ma'am.
Internship.
Ma'am,
Okay.
we are having a NABL certified laboratory in molecular
Okay.
oncology. We have
Okay.
three laboratory.
Okay.
We have laboratory exclusive laboratory for preventive oncology.
Mm.
They do a lot of oral cancer researches. They now they are doing research on. So far, we were thinking that tobacco was the major culprit for oral
Yeah.
cancer.
Yes, sir.
Now they found out that this human HPV in HPV is present in the oral cavity that is causing cancer. So
Okay.
that research was found out in our research in Cancer Institute by Dr. Vijay Lakshmi. She's a molecular oncologist.
Okay.
So they take candidates for internship, ma'am. Most welcome,
Okay.
please.
But what about the projects? They are not supposed to do the project.
Project, ma'am, I'm not very sure.
Okay.
Maybe
Okay.
what I can do, I can share the contact details. You can get
Okay,
in
sir.
touch with.
Okay.
It's one of the state of it's a Center for Excellence laboratory in the country, ma'am,
Okay.
certified by
Okay.
DST. I'll give you
Okay.
the contact. Maybe you can get in touch with them.
Okay, sir. Any help, we can just
Definitely,
contact
ma'am.
them and then we'll get it.
Definitely, ma'am.
Okay, sir. Sir, we are very proud to have you, sir, because you are an alumni of this prestigious institution.
Yes,
And
ma'am.
at this juncture, even I have to tell that I am also an alumni of this great institution,
Oh,
sir.
excellent, ma'am.
So
Wonderful.
your talk was really wonderful, sir. So the students definitely would have benefited, sir. You
Thank
have
you,
dealt
ma'am.
with all the psychosocial issues
Yes,
of
ma'am.
this cancer care, sir. Thank you so much, sir. Thank you.
Thank you,
Thank you,
ma'am.
sir.
Thanks for
Thank you, sir.
attending the lecture, ma'am. Thank you
Yeah.
so much.
Okay. Thank you, sir. Thank you.
Thank you so much, ma'am. Thank you
Yes.
so much for your encouraging words. And ma'am is always behind us, motivating force, saying that do this and do that. And ma'am gives contacts and sends webinar invitations and do this training program and motivate the students to do give speeches. So ma'am is always behind us. Huge motivation, sir. So thank you very much, ma'am.
Thank you.
Uh, Sir, another question from the student. They're asking about the psycho-oncology course.
Yeah, see, psycho-oncology course is available in India now. See, I think three major centers are offering psycho-oncology. One is Cancer Institute at AR. We are offering MPhil and PhD in psycho-oncology. MPhil is a one-year program. PhD, we have both full-time and part-time in psycho-oncology. So that is there. And you also have diploma, postgraduate diploma in psycho-oncology from Cooper, Bangalore. That's only a diploma. That's not a university affiliated program. That's being offered in Cooper, the Center for Psycho-Oncology Research in Bangalore. And you have another fellowship in psycho-oncology that is exclusively for psychiatrists and the clinical psychologist. And you must have MPhil in clinical psychology. If you have MPhil in clinical psychology, or if you have MBBS and psychiatry, MD psychiatry, and definitely then they can go for that fellowship. And these are the three programs available at present. And there are a lot of other courses available abroad, so they can choose. Fellowship is available. They have different programs, PhD programs, Doctor of Philosophy in Psycho-Oncology. They have psychosocial oncology programs. Everything is available. There is but the demand is small. At present, Cancer Institute, we have only 3 seats, but it's a national program. MPhil is only 3 seats available. Bangalore, I think they have 6 or 7 seats. I'm not very sure. But this Tata Memorial Center, Kolkata, which they are offering is, I think, 1 or 2 seats, very limited number.
Okay. Thank you, sir. Another question is regarding the cancer caregivers.
Yes. I understood that. I read that question. Kritika, thank you so much for asking this question. You are very true. You're right. More than the patients, the primary caregiver suffer a lot. We definitely pay attention to them, and they develop fatigue. They are experiencing distress. They undergo a lot of pain and sufferings. Then the suffering is more to the family. When we say family and the caregiver, the primary caregiver, the one who spends more time with the patients in caring them. So the suffering is more. So we need a separate session to deal with such an issue, because it's very, very difficult for me to explain in few minutes. Maybe in another occasion, I'll discuss with Dr. Jyoti, and maybe probably we can talk exclusively about the caregiver's burden. What are the issues and concerns experienced by the family members, starting from their physical issues, their mental issues, their economical issues, social issues, everything. So, for example, one simple example which I would like to share with you, you asked about mom effect. When we say mom effect, the family prevents the doctor from disclosing to the patient about the prognosis. Now, somebody visits the family, just like that, casually. Imagine the amount of stress experienced by the family member, the primary caregiver, because they have to ensure that the person who visits is not knowing about the diagnosis, or if they know already, they don't talk about that particular issue in front of the patient. So that is going to be a huge stress. Not only that, many a time, patient may be aware, the caregiver may be aware, but both think that they don't know each other, that each of them know each other. So this is something. These are all some of the issues that is being experienced by the primary caregivers, and the burden is more among the primary caregivers. So no doubt about it. And thanks for raising a very important, significant question.
Thank you. Yes, I know we do have a cancer caregiver support group in the hospitals. So as sir said, it's a very huge area. It's a very vast area to discuss about it. Definitely, I'll keep it in mind, sir, and I'll catch up with you next time, for especially on the cancer caregivers. And again, they are asking about the reliability of the pap smear tests.
No, I think I shouldn't comment on that, because that should be dealt by the preventive oncologist, because there is a separate division called preventive oncology, and they are trained professionals. Or maybe what we can do, I can respond, but I shouldn't do that, because it's completely dealt by preventive oncology team now, because now everything becomes a subspecialty of oncology. Like psycho-oncology, there is a preventive oncology. They're supposed to answer question. However, see, the biopsy is needed only if something symptomatic is present in the cervix. Say, for example, when we talk about this pap smear test, it is done to see whether any abnormality there in the cervix. If there is abnormality, then they go for FNAC, or if then that is something, that is a concern, then they think about doing a biopsy.
Okay, thank you so much.
Hello?
Even the biopsy test, I got it from hospital. 2 biopsy tests said that the cancer is positive, but still I have taken that biopsy report to another lab. So they tested and they said that it's negative for cancer. So I think tests, we have to be get an opinion with 2-3 opinions that would be correct to go for the further treatment.
But see, opinion also I would sometimes discourage. What happens? Go to the right doctor. That's what matters. Say, for example, they must go to an oncology center. Generally, I'm not blaming the doctors. Sometimes the doctor also not aware of all these symptoms and